DSM, the Diagnostic and Statistics Manual of the American Psychiatric Association. And the Diagnostic and Statistics Manual is a book that's a catalog of mental illnesses. It keeps growing bigger. Starting around 1917, the first document of its type had 17 psychiatric diagnoses. We have the terms change from time to time. Right now we're on the DSM-5. And there was a controversy surrounding the DSM-5. They didn't really change the DSM all that much, but the manner in which they did it set off a controversy. 13,000 healthcare professionals wrote a letter of protest complaining to what they did. What happened is the commission that was set up to revise the DSM was composed of 70% people with ties to the pharmaceutical industry. The first thing they did is they voted, we will all sign an agreement not to explain our connections to the pharmaceutical industry or to say if there was any controversy or disagreement about what we're doing. So they made everybody on the commission sign this non-disclosure agreement. And other people said, that's not science. That's not the way to do things openly and scientifically. There's something fishy about it. So they were very much upset with how the DSM-5, they didn't make that much changes, but the manner in which they did it upset many people. The British Society for Psychology wrote a report complaining and objecting to the procedure. So you should be aware that there's oftentimes sort of politics or spirit of the times things that go on in the creation of these categories. What are the names of the diseases? Well, diseases are named by collections of symptoms. Schizophrenia, for example, and one of the things you can ask, so in the DSM, a mental illness is a collection of symptoms. And what is, for example, I just defined for you, schizophrenia, if a person has hallucinations, you say, why is that person having hallucinations? And somebody says, because they're schizophrenic. Well, how do you know they're schizophrenic? Because they're having hallucinations. Well, how do you know they're schizophrenic? They're having hallucinations. Well, why are they having hallucinations? Because they're schizophrenic. So it's just a collection of symptoms. We don't really know, well, how did they get schizophrenic? We'll say a few words about it. And you can distinguish the germ theory from the DSM from any of the revisions of the DSM. They're all still, basically, the DSM 1 through 5, they're all books listing the diagnostic categories. And when they make changes, sometimes people agree with the changes, sometimes they don't. One example of a controversy in which they changed the category, homosexuality used to be on there as a disorder and a disease. The homosexuals said, we don't like that, we're normal people, we're not insane, we don't want to be changed, we want to be the way we are. And they said, oh, okay, we'll take it off the list. What's the difference between streptococcus and schizophrenia? All right. Well, in the case of streptococcus, we know what causes the disease. You can diagnose that a person has it. Can a person fake it? Well, you can go scrape something out of their throat and see if there's strep in there or not. You'd really have to go to complicated lengths to put the germ in there to convince you. On the other hand, can you trick people into thinking you're schizophrenic? Having seen the video, what did you see in the video? Rosenhans sends patients who are normal. And he says to those patients, I want you to go to the Psychiatric Institute on campus and go check in and say, you'd like to talk to somebody for a minute. And when you get there, say, well, I've been hearing voices, and the voices say, empty, dull, thud. And then, see what happens. And what happens? They say, schizophrenic. And then they put him in the hospital. And then the person is told, I want you to abandon your symptoms and tell them you're normal and you want to come home and be let out. And they won't let them out. They keep them in for a while. And then finally they let them out with the diagnosis of what? Schizophrenic in remission, right? That isn't quite the same, as Rosenhan said, as normal. So all you have to do is say you hear voices and you're going to get the diagnostic category schizophrenia assigned to you. Can you fake it? Can you fake the strep infection? So it's something much more objective about it. One of the questions you can ask about these categories, and there's more than 250 of them in the DSM, are these real things? Is schizophrenia a single disease, or are there many things that can produce these symptoms? Well, if you think about medicine, we talked about scarlet fever before. Scarlet fever means a fever, temperature, sore throat, the person turns red, maybe they have a rash. It turns out more than one bacteria can produce those symptoms. Strep is one of them. If you have strep, then penicillin works. If you don't have strep, maybe a different antibiotic, or maybe there isn't an antibiotic to treat it. If you have one of the other diseases that can produce the same symptoms. So more than one germ may cause the same collection of symptoms. Maybe there's more than one disease there. But once you name it by strep, then you know really what the cause is. You know how to prevent it because you know how strep is spread, and you know how to treat it. But if you know that somebody has schizophrenia, do we know it's the same thing? Two different people with schizophrenia. Do they really have the same disease? Or could there be more than one thing? Next thing we can ask is, are these categories useful? Even if they're not real, they might be useful. So for example, if you look up in the sky and you see this pattern, see some stars like that in the sky at night. What do we call this? Everybody all at once. What do we call this pattern of stars in the sky? You guys haven't seen the stars because we're living in Los Angeles. There's no Los Angeles basin where you can't see them very well. It's been clear enough that if you go out at night, you'll be able to see this. This is the constellation of Orion, the hunter. And there's a story about Orion. These stars are at different distances. Is there really a hunter in the sky? No, but by looking at what's going on in the sky, can you predict what's going to happen on Earth? No. If you're able to fly around in space, they wouldn't form this shape as seen from any other direction. On the other hand, if you said, I was looking with my telescope below the belt of Orion and I saw something new happening there, and somebody else could go out and look in the same place because they know what you're talking about. When you talk about Orion and you talk about the belt of Orion, this is called his belt. See, these are his thighs and so on. I was looking below the belt of Orion. This is his sword, some people call it. Maybe they name it other things. I was looking in there and I saw some object that wasn't there before, maybe some stars going supernova, or you found a comet spotted there, or some other event is happening. You could communicate with another person that knows to call this constellation Orion, even though these things are not connected. They sometimes draw pictures. Here's that little fleck right there, that was a speck of dandruff in his beard. They'll draw a picture of Orion there with his helmet on and his legs and his sword on his belt and everything else, right? But somebody else who knows this pattern knows what you're talking about when you refer to the constellation of Orion. These stars are going to move thousands of years from now. They won't be in that same pattern as seen from Earth if anybody was here. Hundreds of thousands of years from now. But you can communicate, so it's still useful. Even if it isn't real, sometimes it's useful to have a recognizable pattern. And one of the problems that we have is that both reliability and the validity of diagnosis is not what we would really like it to be. What's reliability and validity? So let's talk about reliability and validity of diagnosis. Every test or measure, and this refers to like a bathroom scale that you get on that weighs you, a medical test that takes some blood and looks for evidence that you have syphilis or HIV or some other disease, test for cholesterol that tells you something about what's happening with the chemistry in your blood, an exam in a course like introductory psychology that's supposed to say what you've learned of the material of the course. Any test or measure can be evaluated with respect to reliability, validity, and bias. And reliability refers to the correlation between two tests of the same thing, two attempts to make the same measurement. Or two or more, I mean multiple, let's just say two, at least two, I'll put in here, or more. Multiple attempts. So imagine I have a bathroom scale here, and we have a whole lot of people, and we each get on the scale and weigh ourselves. Right? So we all get on and we get a scale, measures. First time I get on, it says 193. We all get on. Next time I get on, it says 12. I lost a lot of weight in between, I guess. Next time I get on, like 5 minutes later, I get back on the scale, says weight 318. I get back off, I get on the next time, it says 495. I get back off, I get back on, it says 37. That scale is not reliable. So a test that gives you a low correlation between multiple attempts to make the same measure is not reliable. Reliability, if it always gave the same measure to the same person, there was a high correlation between the two measures, that would be a reliable test. Validity, and so to measure reliability of psychiatric diagnosis, the example is for psychiatric diagnosis is the correlation between two different clinicians. Between two clinicians. So it can be done by a clinician as well as by a scale, by an instrument, by a blood test. It could be an objective thing like a true-false test of what students know, or it could be a subjective thing like a clinical evaluation with a doctor who interviews a person and comes to a conclusion. But you have two different clinicians trained in the same system. And that was the whole idea between the DSM, was to try to get clinicians to agree, because they were aware when they got started that sometimes one clinician would say, well, I think this guy's perfectly normal, and another one say, he's nutty, he's crazy. You should take all this money and give it to his heirs. They think he's not responsible to take care of his money anymore. He can't be in charge of a basketball team. You have to sell the team, give the money to other people. People are nodding their heads, you know about some cases like this that happen, right? But then one psychiatrist says he's perfectly normal, knows what he's doing, and another one says no, he's not. And when clinicians don't agree with each other, there's something unreliable. And so the whole idea of the DSM was to try to make it more objective. If the person has this and this symptom, this symptom, this symptom, then we'll say that's schizophrenia. And if they have this symptom and this symptom, we'll call that a phobia, and so on. Now, validity is the correlation between the test and the criterion. In other words, what the test was supposed to measure. So imagine a early pregnancy test that you can buy at the store for only $25. It says you urinate on this stick and you see if something changes color, and if it changes color it means you're pregnant. And what if it's the case that half the people that said they're pregnant aren't actually pregnant? And half the people that had said you're not pregnant actually were? That wouldn't be a very good test, would it? It doesn't measure what it's supposed to. But it's always reliable. So this person, you know, it says pregnant, next day pregnant, next day pregnant, next day pregnant, but no baby. So it could be reliable, but not valid. So if it isn't measuring what it's supposed to measure, same could be true for a bathroom scale. It just always, you know, like maybe it's just measuring your height. Well, that's partly correlated with weight. You know, but it might be reliably measuring something else that, you know, it always gives you the same number. So it might be reliable and not be valid. So if a test is reliable, it may or may not be valid. But if it's valid, it better be reliable. And then bias is if there's a systematic error in the test. Like a bathroom scale might be reliable and valid, but biased. Maybe it's always off by 10 pounds. You know, maybe all the readings are off. You need to adjust it. You know, when nobody's on it, it says 10 pounds. You know, everybody says it's bad. Or maybe somebody else is trying to flatter themselves. When nobody's on it, it says minus 10 pounds. So then they can weigh themselves and say, oh, 125, that's just what I wanted to weigh. Would it be fair to weigh in boxers on a scale that sometimes says they weigh 12 and sometimes says they weigh 350? You know, they have boxers fight each other by weight. You don't want a small boxer going against a really large one. Same is true for wrestlers, boxers and wrestlers. They have to weigh in and they match them up by weight. It's not a valid scale. It could be a biased scale though. And you wouldn't want to have some boxers get to be on the scale that when nobody's on it, it says minus 10. Because then they'd be able to outweigh their opponent. They wouldn't need to make weight for the fight. You know, they could come in 10 pounds overweight, not have to starve themselves to make welterweight or whatever the category is. So we'll be saying more about reliability, validity, and bias, but you should realize psychiatric diagnoses can also be evaluated this way. And one of the problems you saw in the video, Rosenhant's, clinicians aren't able to tell a fake patient from a real one. Now, they could tell a person was, you know, after Rosenhant's did this, like 5 years later, he get a phone call from the guy over at the Psychiatric Institute saying, stop sending us, you know, for the last 5 years you keep sending us these patients, stop sending your students over. He says, I haven't sent you any students for 5 years. I went, oh. I guess they've been kicking a lot of people out. Rosenhant sent you, didn't he? Get out of here. You don't have any problems. Coming over here to talk about the hearing voices. The problem was the clinicians couldn't tell the fake patients from the real, so you have a problem with trying to establish. And schizophrenia is probably one of the most reliable diagnostic categories in the DSM. Now, in old terminology, let me just give you a little bit of an old, we used to have over here normal and neurotic and psychotic. On a scale. So neurotics are just like everybody else except worse. And psychotics are much worse than that. And so these are old terms, you'll still hear them. They're still being used quite a bit in daily language. The main psychiatric category was schizophrenia. In the old DSM, we used to have a lot of subcategories, different types of schizophrenia. The new DSM got rid of many of these categories because the psychiatrist said you can't really reliably distinguish these categories. So they said, okay, we'll get rid of the categories, the subcategories. We'll call them all schizophrenic. But then DSM added more categories, ended up You've heard me gripe already about what they did with autism, where suddenly everybody's autistic somewhere on a spectrum. Freud used this kind of terminology. The joke used to be, neurotic builds a castle in the sky, the psychotic moves in and lives there, and the psychiatrist collects the rent. All right. Used to be the joke about that. But the personality disorders and the anxiety disorders and depression would all have fit in the old days into this category of neurotic, and schizophrenia and the various subtypes of catatonia and various other conditions that have now been lumped together into schizophrenia were in the psychotic category. So a person that's severely disturbed would get that. So you've got to read the chapter on abnormal psychology or psychodiagnosis or psychopathology. All terms mean the same thing. For many of you, it's chapter 14. For some of you, chapter 14 is social psych. Maybe it's in chapter 15. But beware, these diseases are subject to change without notice. So the DSM, the people revising a DSM may change the categories. But here are some of the categories that have been around for a while and that will probably continue to be around for some time. Schizophrenia, characterized by hallucinations, cognitive slippage, a disagreement between a person's emotions and what they say they're thinking about. Mood disorders, including things like chronic simple depression or bipolar disorder, sometimes called manic depression. Case of a manic depressive or bipolar person, they may have a periodic change of mood. And maybe different individuals have different periods. So they may be in the manic phase. And in the manic phase, the person might not be sleeping much. They might be full of excitement. They might be a cheerful manic, meaning that they've got a great idea. They could open a new business. Everybody should invest with me. I'm going to, you're going to double your money. You're going to triple your money. I can't see how this thing could go wrong. We're going to borrow a lot of money from the bank. They might be so cheerful and so sure of themselves. The banks will loan them a lot of money. They're going to open a new enterprise. They don't need to sleep. They're working on their project all the time. So they might be cheerful, not need a lot of sleep, have a lot of energy, be busy doing, active, be, overly optimistic perhaps. And then the same person later would be in the depressed phase, suicidal perhaps, can't imagine anything going right, can't imagine ever getting out of the dump, might be needing to sleep all the time, totally lethargic, might be falling asleep while trying to talk to other people. And then back into a manic phase a bit later. Some of the manics might be the kind that somebody else, they're standing in line, they don't understand why other people are wasting their time by being in line. They'll push other people aside to get to the front of the line, so they'll be the aggressive type of manic. Other people, they're obviously more important than other people, so they will be butting in front of other people and maybe sock them in the jaw for getting in their way and interfering. So some manics will have a tendency to be arrested for doing things they wouldn't or otherwise do, and then be in the... Mike Tyson was a person accused of being a manic depressant of this type. Person that could appear apologetic, and then at other times might bite somebody's ear off or something. All right, so those are mood disorders. Anxiety disorders, so the phobias, panic attacks, things like that would fit in. Social anxiety disorder, a person that doesn't want to be around other people because they don't want to be judged, doesn't want to speak to other people, to new acquaintances, has a fear of that. I'll go through a list of some of the phobias, or many, many phobias of things that people are afraid of. There is a large catalog of sexual disorders. You may study those in Psych 312 to a much greater degree. There are literally hundreds of these. One example would be pedophilia, so that's a person that's philia means love, So pedo, in this case, the person is loving a pediatrician is a doctor that works with children. A pedophile is one that wants to have sex with children. Transvestism is one of the ism words I was telling you about. The things ending in philia are oftentimes sexual paraphilias. Things ending in manias, things ending in ism. So transvestism, a person who wants to cross-dress. So cross-dresser. About 10% of the population have a cross-dressing fetish. 10% of males have a cross-dressing fetish. So a fetish is simply something that gets people sexually aroused. And so about 10% of males, the idea of putting on women's underwear or putting on a woman's bra might give them a little sexual thrill. But a person who's categorized as a transvestite, and nowadays they've added the word disorder to it. So when the transvestism becomes life, interferes with your processes of life, then it's transvestism disorder. And so these are people, about 1% of males are compulsive cross-dressers. What's a compulsion? That's an irresistible urge. And sometimes people misuse the word compulsive. So they say, oh, you know, so-and-so is compulsive, always does her homework. It's always nice and neat and clean and turned in. That's not compulsive. A compulsive is a person that can't stop doing something and it interferes with their life. So they can't do their homework because they can't pick up that piece of paper until they wash their hands. So they have to go wash their hands, come back. They have to go wash their hands. They have to go wash their hands. They can't actually get work done because they have a compulsive behavior they have to do that interferes with actually getting the work done. So a compulsive person is not somebody who succeeds in life by getting their work done. It's a person who can't help but do something else that interferes with life. And so an obsession, that's a thought that a person can't stop having. A compulsion is an action a person can't resist. And the transvestite has the compulsion to cross-dress. So trans meaning across, and vests or vestments meaning clothes. So a transvestite is a cross-dresser. About 80% of the transvestites are heterosexual males. So about 20% are homosexuals. So if a person is a cross-dresser, doesn't mean odds are they're not a homosexual. They don't necessarily want to have sex with members of the same gender. They want to dress in at the age of 12 and 13, they get a big sexual thrill out of it, so it produces a sexual thrill at that age. Later it may not produce a sexual thrill, but it still gives them a kind of psychological satisfaction. Some of them want to go and actually live as a female, then they become called transgenderists. Yes?
That's just what I was about to ask.
And then transgenderist is farther along, and then a transsexual is a person that has gender dysphoria. That's an even more extreme form in which the person doesn't just want to cross-dress, it doesn't just have like periods where they want to cross-dress, but they actually want to change their gender. So a gender dysphoric is a person that's unhappy. They're convinced that they are not the right gender. They have the wrong external genitalia. And they may get sexual reassignment surgery. So that is, so we might as well define them as long as we want them. I'm just listing these as a couple examples of what's in the DSM. But there's a transvestite, there's a transgenderist, there's a transsexual. And a transsexual is a gender dysphoric. That means they're unhappy with their gender. Sister Mary Elizabeth, who is a nun, had originally been in the Navy as a Navy diver, had been an officer in the Navy, a boxer, very robust male, successful in the role of male, quite a tough guy, but always felt he was the wrong gender. Eventually got gender reassignment and became a nun, and now is in the Sisters of St. Elizabeth, in that order. She would come and explain to that it wasn't about having sex with the other gender, it's about feeling that you're the wrong gender. And so she explained that, well, in March of 1983, in the United States, 3 people went in for other surgeries and by accident got gender reassignment. Right? The hospital made a mistake. They forgot who they were. You know, you're supposed to get a hernia assignment. The person looks at their hernia. The hernia's still there. Oh no, what happened down here? Well, the doctors would come and say, all right, you're a woman now. You can readjust. Just be a woman now. And they said, no, I don't feel like a woman. I didn't come in here for that. I'm unhappy. Put it back. Oh, sorry, it's gone. We threw it out with the trash, you know. Can't put it back, you know. We turned the darn thing inside out. We did what we could do. I mean, we thought you were the, oh, that person had the hernia surgery. Well, we thought you were that person. They're also unhappy. They didn't get the surgery they wanted. They said, how would you feel if that, you know, that happened to you? Would you be dysphoric? Would you want to get it fixed? Do you want to have it put back the way it was? Oh, well, you should just accept life the way it is. After all, you know, just somebody tells you what gender you are, and you say, oh, okay, then I guess I'll be that gender. But these people feel like they had the gender reassignment unwillingly, and then other people say, don't you say God makes mistakes. That's what people used to say to Sister Mary Elizabeth. And she would say, if your child was born with a heart valve problem, you wouldn't have surgery. You'd say, oh, God doesn't make mistakes. If your child was born with a hair lip, you wouldn't have it fixed because God doesn't make mistakes. If your child was born with another medical problem, you wouldn't fix it because God doesn't make mistakes about what gender you are, the people would say to her. She'd say, oh. So God makes mistakes, just doesn't make mistakes about gender, what gender you are. So anyhow, those would be some of the arguments, but this is about 10 times more likely than this, which is about 10 times more likely than this, but there's still plenty of these people wanting gender reassignment surgeries. And these are all in the catalog of the DSM. Here's some statistics on prevalence. And I gave you a link, so go look at the links. So if you want to know the latest research, so some of you have older editions of the book, of CALIT. So these are from some older studies. The numbers haven't changed that much. You can go to the NIMH website. There's a link to the website. You can see the latest research on these. Yeah, turn it off because it is the light that's from overhead that's producing that. Panic disorder, less than 5% of the population. Schizophrenia, less than 5% of the population. Obsessive compulsive disorder, maybe 3.5% of the population. Antisocial personality. We want to distinguish antisocial versus asocial personality. Some people are averse to meeting other people. It's more than shyness. It interferes with being promoted at work. Like there's a video I sometimes show of a projectionist. He's a college graduate. He likes to work just to be by himself with the projector and the films. He likes watching the films. They wanted to promote him because he does a great job. But he doesn't want to be promoted because then he'd have to go to meetings with other people. He just likes to be by himself. Doesn't have a girlfriend. He's not interested. Doesn't like to meet new people. He likes being a projectionist so he can be in a room by himself. Mood disorders, depression or mania. Phobias of one kind or another. We're up there above 10%. Alcohol or drug abuse. Any disorder, like a third of the population. Now you're going to see in the NIMH website broken down by at any time during a person's life versus has had any disorder treatable in the last 12 months. You're also going to see estimates in one of the websites of the cost of medicine in the United States, including mental health. The United States spends $1 out of every 6 that's produced in this country on medical treatment. We spend more of our GNP, of our gross national product, on medicine than any other country in the world. More than double the next country down. So we have the most expensive healthcare system in the world. According to the CIA, we have the 30th best of nations. We're the worst in the industrialized nation with respect to childhood mortality, so babies die faster in the United States than in other countries. With respect to nosocomial infections, so people die in our hospitals more rapidly than they do in other countries. We have the 30th best healthcare system, but the most expensive one. About a third of the money is being spent on mental health. $2.7 trillion a year. That's as much as the Iraq War cost. So these are huge problems, huge numbers of people. You can look at the incidence, you can look at the cost in the various links to websites. You can get the updated statistics. There are quite a few studies that are put there. There's one with lots and lots of data if you're writing a report on this. So those of you that are interested in that or want to become involved trying to deal with the problem and want to understand just the nature of the problem of mental illness. Now I talked about reliability, validity, and bias. Here's an overhead on it, and I want to call your attention to a slogan at the end. So any test, diagnosis, or like a biological test, a medical test, an examination in a course. We'll say more about test theory a little bit later when we get there. But you should remember this ballad. If it's not reliable, it's not valid. So if it's not reliable, then it's not valid. So if the scale will not give you the same result twice, you know it can't be valid. Scale that says I weigh 300 pounds one day and then 5 minutes later says I weigh 12 pounds, you know that's not reliable. Now there are psychological tests that are totally unreliable, and so we know they're not valid. The Rorschach is one of them. It's a famous test. Some people are still giving it. It's amazing to me that it is still in use by some people. It's not reliable. There are people who try to work. We can't give up on this test because we love the test. So we've got to make it reliable. So they invent scoring systems. And the reliability comes to next to zero. It's like, no, it's a little above zero. Here's a famous unreliable test. The TAT was another test. Let's see if I can maybe get more of it on the picture at once here. And here's the way the test goes. It's called the TAT, the Thematic Apperception Test. It's based on the theory of projection, which is you ask people what they see and they find out what's in their subconscious mind, things they don't know about themselves. So you say, what do you see in this picture? That's the same idea as the Rorschach test. What do you see? People are afraid to raise their hands at what they see in the picture. But you can tell any story you want. Somebody invents a story about it. Some people say, well, it's just a way for psychiatrists to get somebody talking. They want to get them talking. They give the test. But can you learn something from a test like this? Well, if she says, oh, this is Snow White, and there's, she got a poison apple, she's got a poison hair. Wow, paranoia, I see. And if the person, she's looking in the mirror saying, what am I going to look like when I'm old? Or the old person remembering, what did I look like when I was young? Or people make up all sorts of stories. Do you actually learn anything? Well, the reliability of two clinicians giving the same test, two doctors give the same test, do they agree on their diagnosis? And the answer is no. And if they try to score it, do they agree on the scores? And the answer is no. They're not reliable. And if it's not reliable, then it's not valid. There's no point doing these tests if they're not reliable. Now here's some of the phobias that I was telling you about. Here are some of the things people are afraid of. Bugs, mice, snakes, and bats. Heights. So that's acrophobia. So an acrobat does tricks up at great heights. Right? So the person does gymnastics at a great height. They're an acrobat. And an acrophobic is afraid of heights. like in the movie Vertigo, if any of you have seen that old classic. The Titanic movie, water. Now, a person who's afraid of water is somebody that, you know, I'm going to take you for swim lessons today. No, I don't want to go there. In fact, a person won't go to Cal State Fullerton because they heard we installed a pool on campus. You know, so they won't go anywhere near the campus because they're afraid of the pool. If it interferes with your life, a lot of people are afraid of things. If it's a rational fear, it's okay, but it's called a phobia, or now they've added the word phobic disorder. It's a phobic disorder if it's irrational. It's excessive. And it interferes with life. So these are the criteria. Somebody says, you know, oh, you're afraid to run across the freeway? What are you, phobic? Chicken? Coward? You know? That's not an irrational fear, that's a rational fear. A lot of people get killed trying to cross the street. Freeways, the cars go, and apparently train tracks, the trains go faster than it looks like they're going. People get run over in rail crossings all the time. It has to be irrational, it has to be excessive, and it has to interfere with life to be called a phobia, to qualify as a phobia. So here are some of the phobias. We've got public transportation, storms, closed places. So that's claustrophobic, who's afraid of being closed in the elevator. Tunnels or bridges, speaking in public, crowds, and speaking to new acquaintances. Here's some statistics on schizophrenia. So people have asked, what is producing schizophrenia and depression? And looked at, one of the theories is these are not caused by germs, but by genetics. Maybe these are genetic disorders. Now don't rattle till the class is over. Still have like 3 minutes here. About 1% of the general population is schizophrenic. And again, I put a link to a newer study and a link to a schizophrenia support group website that has lots of educational information and research information, as well as information for people if you know schizophrenics. And if you know 100 people your age, you know somebody, probably 2 of my close friends developed schizophrenia as they got to about college age. So you will know some people that will acquire this problem. In the grandchildren of a schizophrenic person, about 5% is the incidence. The parents of a patient who's been hospitalized for schizophrenia is about 6%. Half SIDS, the incidence is about 6%. Full siblings, the incidence is about 9%. Children of a schizophrenic, about 13% are schizophrenic. Children of schizophrenic mothers adopted by non-schizophrenic mothers, 17%. I wouldn't make anything of this 17 being higher than the 13. Not clear to me that the being adopted. They used to have a theory that the mother had something to do with causing schizophrenia in the children. So there was some blaming of the mothers of schizophrenics. They would call them schizogenic mothering. And the description that the psychiatrist gave was that the mothers that say, "Come to me." "No, don't hug me. You'll get your stuff slobber on me." "Oh, but you don't ever hug your mother." "Ah, get off." And that was the description of the schizogenic mother. I don't know anything about that. But also, we don't have any evidence here that being adopted by a non-schizophrenic mother did him any good. This number is not any lower anyway. Fraternal twins, the incidence is about 17%. Children of 2 schizophrenic parents, about 46%. And identical twins, 48%. Paul Meehl used to ask his clinical doctoral students in clinical psychology, he said, if you don't know anything about a patient, about them, and you want to predict who is going to be schizophrenic, what would you use to make your prediction? And typically these students would come in, this is in a doctoral orals where he's allowed to ask anything, And the students would say, oh, well, they come from a bad background, or their family split up, or they witnessed violence, or you know, they come from a impoverished country or something like that. And he'd say, no, no, no. If they have an identical twin that's schizophrenic, it's a good bet. That's the highest. You want to bet who's going to be schizophrenic if somebody has an identical twin that's schizophrenic. About half of the twins are schizophrenic. Now you saw in the video, there are not concordant. These are called concordant cases, where both twins are schizophrenic. You have discordant cases, where one is schizophrenic and one is not. And people are trying to study those cases, trying to understand what was it about one twin versus the other, if they theoretically had the same genes, that may have induced schizophrenia in one but not the other. And then they look for things like what you saw in the video, maybe viruses or drugs that one might have taken that the other didn't, or various other accidents, like one might have been in a traffic accident or something like that. So they try to look for other things that maybe schizophrenia is genes plus something else that triggers the onset of the disease, or maybe just chance. The person has the genetic potential and some event chemically happens within the body that happens by chance that triggers the onset of the disease. All right, that's it for today.